Why did I wear this cap? You're so ultra prepared. Watching this one, tell me when it's okay. Right there. Yeah, I need to read it.
Thank you for submitting your exercise 3 to Dropbox, and we hope to have that back to you Tuesday of next week. And then the final exercise is a journal article critique that's available to you also. And let me check when that is. And then that will be, submit that at the end of the evening on December 8th. Exam 2 is then on December 19th. For those of you, well, you folks are going to be taking it here. We'll be using the same room for Exam 2, and we need to get to you. Who's going to come for the first session, who's going to come for the second session. So, yes.
December 19th?
No, 9th.
9th.
December 9th, yes, yes. No, I think everybody will be gone by then. So, yes, December 9th. Any administrative questions, any issues, problems, requests? Exam 2 is very similar to Exam 1. Once again, multiple choice, some calculations. Okay. Shall we continue? Questions? All right. Let's see what we have here. Okay. You all saw our author of the text that we use, Leon Gordon, had an obituary in one of our professional journals, American Journal of Epidemiology, and we learned that he died recently. In the obituary, Dr. Leon Gordon, one of the most revered professors of public health, died on September 7th, 2015. And he certainly did contribute so much to the field of epidemiology and has been instrumental in sort of be the background teachers to everyone that is interested in learning about basic epidemiologic principles. Go back. Some other interesting, actually very related items that were in the New York Times this morning in terms of early prostate cancer cases fall along with screening. So this is very similar to the breast cancer screening advisories that we were discussing earlier in the semester, and the same group, the United States Preventive Services Task Force, made some recommendations in 2012 to sort of reduce the screening efforts for early prostate cancer with the sort of view of too many potential cases were being identified and placing a burden on men who then needed to decide what their next course of action would be, and usually at that time there would be the opt into treatment. And so screening for prostate cancer, like mammography for breast cancer, has long been a subject of intense debate. With the two sides of the story, with advocates insisting that it saves lives and detractors arguing that it leads to too much unnecessary treatment. And so with this decline in screening and incidence, quote, could have a significant public health implications. And so right now we're sort of in that testing phase. We've got reduced screening practices, and we don't know whether or not we're going to have a good turnout or a bad turnout. So we need to continue to monitor our vital statistics, mortality data, and cancer incidence data. And then a good piece of news, Guinea, the last nation with Ebola, may soon be declared free of virus. And so this epidemic has been going on for about 2 years or so, in primarily 3 countries, Guinea, Liberia, and Sierra Leone. And this outbreak has killed approximately 11,300 individuals. And the majority of them were from those 3 West African nations. This last case is an infant with real resilience towards this Ebola. The Ebola really was much more difficulty for younger ages, higher incident, higher death rate in younger ages than older ages. And so if no further cases emerge in Guinea over the next 42 days, and 42 days is the equivalent of 2 incubation periods for the virus. You all know what all of those terms mean. The nation will be declared officially free of Ebola. And as I was saying, that was for 2 years. So lots of things to keep up with in the news. I thought I'd start with a little bit of review because recently we've been discussing some of the more sophisticated, complex issues of epidemiology, and certainly the topics, the principles that we as epidemiologists bring to the table as experts in the field of bias, confounding, and interaction. What a strange thing to say that one is an expert in. And so remember, our goal is to design and conduct valid and reliable study using sound methods, sound data analysis practices, and we're always thinking in the back of our mind what could contribute to our study design, our data collection, our analysis, that could potentially bias our results, confound our results. And so important factors, random error, bias, confounding. Remember, our first step is that we want to be internally valid. We want the study that we conduct to be valid. So at that point, once we establish that we have internal validity, and through investigating potential bias, controlling for potential confounding, and discussing interaction. Remember, we cannot control interaction. We look for it. We need to do our stratified analysis, for example, and just say, okay, we've got this interaction. We can deal with it. Let us tell you how it's working within our study. Once we get that internal validity, then we can generalize to the larger target population. And so the ultimate goal of being able to generalize our results to the external population. So who would like to describe this figure and tell us what it means in terms of confounding?
Confounding must be related to exposure and outcome.
That's correct. We've got a confounding factor of age in this figure, and in order to be a confounding factor, it must be related to the exposure, and it must be related to the outcome. Okay. But it does not, sometimes this is a confusing factor in terms of it looks as if age is between the exposure and the outcome, but it's just sort of out here in space. It's not necessarily, it is definitely not an intermediate factor, okay? Confounding is not an intermediate factor. To be a confounder, it must be related to the exposure and the outcome. The confounding, to reiterate, the confounding variable must be associated with both the risk factor of interest and the outcome, as stated very nicely. The confounding factor must be distributed unequally among the groups being compared. And it cannot be an intermediate step in the causal pathway, okay? And someone, or you may be asked in the near future, if an intermediate factor is another type of confounding variable, and you would say no, or if it's asked as a true-false question, you would say true or false, however that question should be answered. We can control for confounding, and it can be during the design phase or the analysis phase of an epidemiologic study. Okay, so previously, the few slides in front of this, we had age as a confounding factor. And so that is a relatively easy way to use restriction during the design of a study. If we know that something operates differently for younger ages versus older ages, perhaps we could restrict our study to all individuals less than 20 years of age. And that's an example of controlling for confounding during design using restriction. Perhaps we know that there is a differential physiologic mechanism between males and females for a certain type of drug that we're studying, and we already know that there is a difference between genders, so we might want to restrict our study to males or to females in order to get some additional information on the pharmaco properties of the drug. We can also, during the design, use matching or randomization to other opportunities for control of confounding during design. And then during the analysis, our plan of analysis should always start from basic descriptive analysis to maybe 2x2 to categorical to then on to our more sophisticated modeling. So if we were worried about potential confounding entering into our study and tampering with internal validity, first thing that we would do is stratify. To stratify, you take a variable and you determine, okay, are there any way that I can turn my variable into a dichotomous or an ordinal variable, or a categorical variable. That's sort of the first step in stratification. If my variable is gender and I want to stratify by gender, it's a dichotomous variable. It has two possible choices, male, female, and in terms of the classical definition of gender. And so stratify by males, by females, and see if the analysis, if your odds ratios are similar for those two categories. If you have a continuous variable, such as weight or height or blood pressure, that can always be categorized into ranges. You might have less than one, for blood pressure, less than 120/80 versus above. Then you have two categories. You're stratifying on blood pressure. If you have certain, for example, when we are developing applications for funding and submitting to the NIH, we always need to place our potential study population into a table by race and ethnicity. And the classic strata are Hispanic, non-Hispanic strata, or for race, our strata are African American, white, Asian, Native American, etc. And so, once again, you make your groups, conduct your analysis within the groups, and compare to see if you have different odds ratios or different relative risks among or between the groups that you're interested in. And then the final issue discussed was interaction, or also called effect modification, a more modern term in epidemiology, and that's probably the term that is used in when you go on to taking Epi2. And as I mentioned, unlike confounding, interaction should be described and reported rather than controlled. It happens, and we just need to know that it happens. An easy, straightforward example of interaction, so that it can help to remind you what the definition of interaction is. Cigarette smoking and radon exposure are two possible risk factors for lung cancer. Lung cancer, the outcome. Cigarette smoking and radon exposures potentially leading to the outcome? Is there an interaction between cigarette smoking and radon? If the risk of lung cancer from cigarette smoking is the same among those who were exposed to radon and those who were not exposed to radon, there's no interaction, okay? But if you find that individuals that smoked and were also exposed to radon had a higher incidence of lung cancer versus those that also smoked but did not have an exposure, then you might be dealing with something that you need to describe. Once again, not control for, but describe. Now, you should be comfortable with defining and understanding additive interaction and multiplicative interaction. Okay. We have, let me get back to this. Let me go here. Here's an important question for you to tinker with over and over. Once again, it doesn't matter, the numbers in these boxes don't matter, but the method for solving for the empty box is the concept that you want. Yes?
So I understand how to do both of them, like how to do the calculations to get the empty box, but I don't necessarily understand why we use each method. Mm-hmm. Like, what is the significance behind each method?
Mm-hmm. Okay, and so that potentially could be in terms of a biologic mechanism or an environmental mechanism. Exposures act differently. Okay. And this is are two methods or ways in which exposures interact with each other. They can be additive or they can be multiplicative. It helps us to understand how exposures react in a general environment. We may have different we may have different interventions depending on the mechanism. So this helps us to determine what the mechanism is and how best to then explain what is going on. Mm-hmm. Melissa.
Is it measuring severity? So if you have some elements that have a multiplicative interaction, it's more serious because
not right. Not necessarily. Okay. It depends on the disease, and it depends on the incidence of the disease within the population that you're studying. So don't fall into the trap of saying that, oh, if we found that it is additive versus multiplicative, it's not as severe. It does not mean that at all, and it depends on, once again, the disease, the incidence of the disease, the population that you're looking at. So you need all of that information to answer that question of, okay, is this more important than the other? That I think that is, I think that's a question at the end of one of the chapters, and or on one of the quizzes. And it's just that you just can't say additive versus multiplicative. You need all the other information that goes into it. There's a question behind it.
So then, like, for our purposes, like for the exam, is it just important that we know how to get the answer if you say using the additive model or using the multiplicative model?
That's correct.
We don't need to answer like any other questions about.
Right. Okay. And so this figure and this figure, the additive, and right, both very important for the exam. What I'm saying is there may be a question, is one more serious than the other? Or, you know, we learned that, we found that it was the additive model, and so it's not as bad. There are less consequences than the multiplicative model. And true or false, and you have to say, no, it's false, because I need to know the disease. I need to know a little bit more about the study population, the incidence of the disease. So, yeah. Thank you. Okay, good. All right, so you did those last week. Okay. An item on quiz 9. Now remember, exam 2 is not cumulative. Exam 2 is the second half of this course, and just to remind you that exposure. So quiz 9 was in the second half of the course. Exposure to cigarette smoke is a sufficient cause of lung cancer. Okay, we've gone over necessary, sufficient, and so when you read that sentence, the first thing that you want to do is define for yourself in terms of epidemiology, what we've discussed, what is the operational definition of sufficient cause? And I asked my colleagues in the room today, what's the operational definition of sufficient cause?
The exposure by itself can cause the disease.
Okay. And so exposure to cigarette smoke is a sufficient cause of lung cancer.
Want to modify that?
Okay.
Sufficient cause, like, needs, or I'm gonna go somewhere else. But in this case, I feel like it's not sufficient because there are other factors at play that need to happen for the lung cancer to occur.
Mm-hmm. So how would you restate it, or okay, we've got another hand up, so I'm going to throw it back there.
I was just going to say that in order for it to be sufficient, doesn't it always have to cause the disease?
Mm-hmm.
And smoking doesn't always cause lung cancer.
Okay. Good. Does that, anything else that folks want to add?
Yeah, what it said. I don't think it's that way. I think to be sufficient, every smoker must have lung cancer.
Yes, and that's what exactly, and that's what Anthony was saying. Yes, right. And we all know that everyone who smokes does not end up with lung cancer. You know, it may be because they've died from a competing cause of death, or they don't live. Well, same thing. Just don't live long enough. Don't have the other triggers for them to go down that path. Okay. Intermediate variables in a causal pathway are special types of confounders. Yeah, allowed false, and that's what we talked about earlier. And I didn't want you to be confused with that diagram with age being up there. That meant that age was between the exposure and the outcome. Confounders are not intermediate. Okay, they're related to the exposure, they're related to the disease, but they don't need to be in the middle there, or immediate cause. Does this bring up any other questions from some of the other chapters or quizzes? If not, I will continue. Okay. I am primarily using slides that you have that are labeled lectures or slides for chapter 17. Is this chapter 17? Yeah, okay. I am not going over all the slides today, okay? But that does not mean that these slides are more important than the other slides. I just thought it, just in terms of an oral presentation, we didn't want to sit here and read all the slides today. So clarification there. Yep, chapter 17. Okay, with chapter 17, we also entered into the third section of the text. And the third section of the text is really quite different now. We've got our basic principles and concepts of epidemiology, and we now want to maybe apply them or use them in the real world in other disciplines. And so we're going to be talking a little bit about health services, policy implications, a little bit about legal analysis and law. And so basically applying epidemiology to evaluation in policy. And this is, you know, sort of the outcome of epidemiology and why it might be important. Oh gosh, why do I have to know about an odds ratio or relative risk? Where is it important? I'm here in a school of public health, and I want to learn about how I can best take care of the public's health. And so we'll begin to start talking a little bit more about the global aspect or use of epidemiology. So chapter 17 primarily reviews some of activities and tasks that would be contained within the discipline of health services in basic tasks of health services, and really using some examples here. We all know that health services is, you know, much more sophisticated and in-depth discipline, as all disciplines are, but we're using some nice basic examples, starting out with process and outcome, and how we can think about studying the process of healthcare administration, healthcare services, and outcomes of those services. Gee, sure sounds familiar to how we might conduct an epidemiologic study. Process, we can begin to think about them as our sort of our exposure factors, and then our outcomes, rather than being a disease, disability, the outcomes are outcomes of health services, for example. And so we're thinking more about how to provide the best care as possible. We may have one group on the north side of town following some type of healthcare procedures, screening procedures, very different from the group in the south part of the city. And we now have the ability to make those comparisons using the different processes that the healthcare providers are using, follow them in time, and then see what the health outcomes are in those two groups. And we can begin to make assumptions that what's going on in the north what they are doing, the processes that they are following, compared to the processes that are being followed in the south part of the city, actually has an effect on the health of their populations. And so we can then learn from those analyses and change potentially health care. So once again, a process means that we decide what constitutes the components of good care. Hopefully, your healthcare provider is always selecting a process that has an outcome of good health. Studies the process of clinic or healthcare provider. How do we do this? We might be reviewing records. We might actually sit in a emergency room, a clinic, and observe what's going on. They're not triaging very effectively. Wait time, observe wait times. The patient has been sitting there for 2 hours, for 3 hours in the emergency department. Very important variables to observe, because after that individual is discharged from the ED, someone's coming up and doing a satisfaction survey. Well, were you satisfied with the care that you received in that emergency department? No, I was sitting there for hours and hours and hours. Okay, and so those are the type of questions, the type of issues that, once again, yes.
Wouldn't this kind of like overlap with quality improvement, people on the policy side?
Sure, exactly, yes, yes. It can also be called quality improvement, and great observation, great observation. You know, we're beginning to have a real blending of sort of these new areas that are coming into vogue. Outcomes research, when it first began to be used not that long ago, epidemiologists would all sit there and go, it's just epidemiology. Why are they all excited about outcomes research? But no, it was also great to see that we could then help these folks that light bulbs were going off in terms of outcomes research. Quality improvement, great. You know, actually that brings up a caveat. The OHART, Office of Protection of Human Subjects for Research, their guidelines, the guidelines that we're operating under are from the 1980s, and so right now the new changes that they're promoting are out for public comment. And Dr. Bill Duncan, who is our Vice Provost of Research here at ETSU, held a few sessions over the past couple of weeks in terms of what type of comments would we as employees or students at ETSU, what do we want to give back to the federal government in terms of how these new policies and procedures would affect us. And there's always been a question when folks go to the IRB, at least I'll use ETSU as an example, in terms of quality improvement projects. Does this need to be reviewed by the IRB? And if you're in a more conservative institution, they'll say yes. But now the new policies, if they are adopted and accepted and adopted, would no longer require any quality improvement project to have to be reviewed by IRB, because the argument is it takes a lot of time and resources to review such a project when really they're being done to help health services, and really would not have risk benefit issues associated with study participants. Anyway, sorry, you said quality assurance, and that's it's all related. It's all related. But thank you. Yes, that is. I thought you were raising your hand. You're only putting your sweatshirt on. Okay. Okay. So process. Why are we studying this? Why do we think these things are important? With a process measurement, we can determine what percentage of patients have had their blood pressure measured. Well, what's a major public health issue in the United States is that we have so many individuals with undiagnosed high blood pressure walking the streets. Okay, and undiagnosed high blood pressure because they've never had their blood pressure measured. They feel okay. You know, really, in terms of, unless you're at extreme ends of the spectrum, you can have high blood pressure and not know it. There are usually signs, symptoms go on with your normal daily activities until you have a heart attack, you have a stroke, and then they find, oh, you've been walking around with high blood pressure for the past 5 to 10 minutes. And so this is why these process measures are so important for public health. But, you know, you also need to remember what you're measuring. You're not measuring the health of your data collection is not necessarily measuring the health of the patient, the health of the clients within a group. But once again, how can the health service practice, whatever you call them, do better so that really in the long run you're thinking about population health. Interesting last comment here, or last sentence, is process assessments are based on expert opinion. So let's go back to the U.S. Preventive Task Force, where they come up with, they review the literature, they do review clinical trials, meta-analyses, et cetera, and they come up with their recommendation that, well, one should not begin to screen for prostate cancer until, you know, males are 50 or 55 or something like that. And so that's basically what this sentence means. Is that criteria 100% correct, appropriate? We really don't know. And also, they change over time, and so it's very important for your healthcare providers to keep up with that literature also, not only the disease-based literature, the health literature, but the process literature, in order to make sure that they have practices that will help keep you healthy and everyone else in their practice. So when we're talking about outcomes and health services discipline, they are studies of outcome determines whether or not a patient benefits from the care provided. Once again, the care provided is your exposure variable, and your outcome is the type of benefits or non-benefits from the care provided. And naming the different type of outcomes that we might be interested in. patient satisfaction, quality of life, and degree of disability. And so another fairly recent group that has made a significant impact on, a significant impact on outcomes research is a group called PCORI. You may have heard about PCORI in some of your other coursework. Patient-Centered Outcomes Research Institute. And this group was established within the past 10 years and has a significant funding operation to look at patient-centered outcomes, patient satisfaction, quality of life, degree of disability. And a recent study that was funded, there was a funding announcement titled Patient-Centered Models of HCV, Hepatitis C, Care for People Who Inject Drugs. And a little over $14 million was awarded to a medical center in the state of New York just in 2015 for 5 years. And in this study, this is pulled from their abstract, in this study, we will study both direct observation, where are we? Directly observed treatment and patient navigator models. And so we've got two groups. We've got patients that will be randomized to directly observed treatment. Okay, so you've got individuals, drug users that don't reliably take their medications, but if you can put them on an 8-month course of certain type of the new treatments for HCV, you can cure them. And so it's worth sometimes to sit there, directly observe their treatment, or compare that to patient navigators. Patient navigators are individuals that help the clientele navigate through the medical system. It's not an easy thing to do, and when you have other things that are taking your time away from your normal daily activities, sometimes, sometimes it's helpful to have someone else say, oh gosh, remember your appointment is tomorrow, or remember you need to take your medications, whatever. And so the goal of this group is to find out which model produces the best results in terms of treatment and is preferred by patients, okay? We cannot assume that they like the patient navigators. Perhaps they say, why is this person here? Get them off my shoulder. Or, perhaps they don't want to be directly observed as they take their pills or whatever. And so in our analysis, we will examine which treatment works better. We will compare the proportion of patients in each arm who. Okay, a very simplistic, basic way of determining what is working and what is not working. Proportion. Remember, proportion, a percentage, easy to calculate, easy to fit those folks in that 2x2 table. Hopefully all of you can put, you've got your 2x2 table, you can put your patient navigator, the two columns down, and your directly observed treatment, your 2 rows over, and you can put all your study subjects into the 4 boxes. You would have a different box for a proportion of patients in each arm who initiate treatment, adhere to medication, complete treatment, are cured so that they have no virus in their blood, and become reinfected. And so, you know, a timely example of outcomes research, it's here. We are putting a lot of funding into patient-centered outcomes research. We are now realizing that just because we think we have the cure-all drug doesn't necessarily mean that it is going to work, because it may be difficult to take. It may lead to significant side effects and make a very dissatisfied individual who then stops taking the medication, ends up with some, you know, drug-resistant condition, and everything just falls apart. Okay, and so another way to think about what you might be measuring as an outcome, functional status, quality of life, satisfaction, costs. Costs are also another very significant outcome variable to measure in outcomes research is cost. If we do this in our practice, will it save us money? Will it save us time? Will it, you know, save us the number of other resources, number of staff that we have to have working on a Saturday? Process measures, examples of process. Remember, process is an activity, steps taken to get from point A to point B. If you have a screening program, you might measure the number of people who actually come to the screening, the number of screen positives. You might have a network. You have told all the primary care healthcare providers in a region about this screening opportunity. You may, and they have told you that they have referred their patients to the screening. Do the patients actually get to the screening? Compliance with referral, and then outcome detection rate. Intermediate outcome measures after you've done your screening. What are the other type of things that you can measure that will help you to determine whether or not it's been a success or not a success? In terms of if you are screening test quality, some additional examples of process measures. You're actually, it's an active thing. You're doing something. If you have a list of process measures, A through D, and you're asked which one of the items below is not a process measure, remember to look for that active verb or activity within a phrase. That is what process measures are. Final outcome measures, incidence rate. We know how to calculate those. At the end of our outcomes research, we may calculate an incident rate, mortality, adverse events, quality of life. So very similar to what we've been discussing as you've been introduced to epidemiology. Okay. So bringing in some additional or some terms that we've used in the past. Efficacy, what type of trial would one design if you were testing efficacy? And let me give you a hint. We've learned about phase 1, phase 2, phase 3, phase 4 trials. What type of trial would be designed to test efficacy? I think I heard phase 2. Yeah. Yes, and the winner is. Yeah. Remember, you start. So you start thinking about, okay, 1, 2, 3, 4, 5, 1, 2, 3, 4. Phase 1, safety. Okay. Phase 1, you're doing safety. Phase 2, efficacy. Does the drug, the agent, the device, the intervention work under ideal lab conditions, under experimental design? Okay, efficacy, phase 2 trial. How about what type of trial for effectiveness? 3, yeah, that's good. And you are conducting these trials in more of a real-life environment, not as investigator-dominated or observed, but once you're getting ready to put the new product on the shelf at the pharmacy, first you want to see, okay, real-life conditions, is it effective? And then, so once again, very similar to what we were doing when we were talking about epidemiologic designs. Now we're talking about health services, asking questions in a little bit different way or different type of questions, but the underlying concepts are the same. Efficacy. Efficacy has a definition, and it means the same for all disciplines. Effectiveness, once again, same definition. And then efficiency we haven't discussed as much, but that is more of the cost outcome data that we would glean from the health services outcome study. And remember, think about those broad definitions of cost, money, personnel, time, also including discomfort, pain, absenteeism, disability, social stigma. So almost, you know, what's the cost to the company? What's the cost to the institution? What's the cost to the individual? What's the cost to society? So there are some criteria that can be used that to allow you as an investigator, a researcher, someone trying to improve health services to think about, all right, I think my outcome measure is going to be this, but let me go through some questions and see if I'm able to express its effect in quantitative terms. Okay, you need to be able to measure it. It should be easy to define and diagnose. if we don't yet have the diagnostic criteria for a syndrome, for example, it's probably best that it's not time yet to do these outcome measures because we have no idea what we're diagnosing. If we're not diagnosing correctly, what type of bias can we end up with? Misclassification. Okay, so we may classify someone as having the disease or not classify someone as having the disease. So yeah, think about, there's selection bias, there's misclassification bias. Those were the two biases that we spent the most time on. Should lend itself to standardization for study purposes, meaning that there should be an operational definition. We should, a standard way to measure it, to record it. We could give someone a sheet, for example, that would tell them, do this, 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 and we could use that same sheet, train everybody how to do this, to do that, and it would be a standardized methodology. Population served must be at risk for the condition being evaluated. Okay, that seems obvious, but sometimes we don't think of those things. That's why it's nice to have sort of this checklist of criteria for selecting an outcome measurement. And then the most appropriate measures that we select should depend on the specific questions being asked. Sometimes we just don't ask questions that match what we're really trying to measure or get at. And what am I doing? Oh, that. Yes, question.
Yes. What about if there's not agreement in the medical community on what the diagnosis is? So there could be like 2 or 3 sets of different ways to diagnose certain disease. How does that change if you're going to be doing a clinical trial? What you choose as your outcome?
Sure. And that's when you would have to have consensus, right? You want to make sure that you have standard operating methods, a manual of operations that everyone will receive, get trained on, and use. And so you bring up a good point in terms of you then may not be able to use past cases because Group A was using different criteria to diagnose versus Group B versus Group C. And that does happen. That does happen. We know that if we go to one healthcare provider, we may get one piece of information. We may go to another healthcare provider. We may get information that is completely opposite from the first individual that we went to. It's the whole thing of getting the second opinion, the third opinion, the fourth opinion, until finally you go to enough where they're all saying that you have A, you must have A. Key question, key point in terms of standardization of practice, standardization of research. Where can I use these instead? Okay. A specific example, outcome measures, if you were going to run a vaccine program, how might you determine success of your program? It may be based on the proportion of people that were actually immunized. You may know your denominator data. You may know the number of children or school-age children in a population, and you want to get as high as possible, 80% or above, in terms of flu immunization, and you might calculate proportion of school-age children within community A who are immunized. Number of people at high risk who are immunized. We know with flu, for example, that younger and older aged individuals are at higher risk. Pregnant women, and proportion of people at high risk who are immunized. And further examples. People immunized who show serologic response, people immunized and later exposed in whom clinical disease is not developed, meaning CDC correctly identified strains for inclusion into flu vaccines. And all right, folks that are punching the air, I keep thinking that you have a question. And then people immunized and later exposed in whom clinical or subclinical disease does not develop. So, you can start easy and then get further and further into health outcomes as your measures. A picture, a figure that describes epidemiologic studies. On the left-hand side, health services studies. On the right, and the fact that healthcare is being used as the exposure factor in the on the right side, and healthcare can be affected by environmental and other factors in terms of availability of health services may be an environmental factor. The healthcare may be great, but it's absent, and so that could lead to poorer health outcomes. And then on the epi side, environmental factors leading to health outcomes, and that relationship can be affected by other factors, including healthcare. So sort of a nice pictorial to think about how the approaches are very, very similar. Okay, let's stop here for a break and reconvene at 2:15.
Yeah.
What? I have
I was just reading for Christian because I saw the time.
Are you your message actually, but I never, I always like, you know, everyone else. But, have you had
the process, I think,
Yeah.
Yes.
And when you wrote about opening a clinic, I was like, that's not our instrument.
Yes, it's not. So, you said increase the access, or increase the yes. So then I would have to change that. What I was thinking was, so like opening up.
So our intervention now are to programs in the public health department, and do like for info about like so those are the two interventions. So why are we building supply or not hydrogen?
Or the intervention capital.
So they're not the same.
It does, but the intervention I think we're changing. Like one of the properties that can't do. Well, I just went in and I was gonna make a comment on it, but then we have to change. Yeah. When I got here, I was already walking down here and I didn't. We just changed the process. If we change the process, our intervention has to match, that intervention has to match that process.
Yeah, because it's like a classroom.
So are they know they're done?
Intervention, if we can make it like reworded to line up with
that we have.
the word. Yeah, I feel like
Rather than saying and power and education and all that. Well, I'm confused about what I previously thought more in my head there's like describing the process how are you impacting you're saying that the intervention like not a project with the outcome of the intervention.
Yeah, the intervention should be and also the process objective number one was that she said it was the impact like private metro for it.
I need to go back to make sure that it's combined.
For the most part, I would see that. We're also managing the determining the connection between reproductive age and you report you have. Oh, and I forgot. Final report sounds amazing. I've never heard of all that. And we're describing our audit. We're at high risk.
You posted on what their commentary? Sorry, increase number of
They said that they had to be submitted by yesterday. No, I'm sure. I don't know. I got it. So, everyone's just like busy doing the project, like I don't have time to look over
just be creative.
Yeah. Okay. But,
I was wondering why I can't
I either want to like, do it early and then done. Like it has to be measurable. I bet you. I would like. I would find that. 6:30. Okay, let's get back to. Our good data. I just couldn't find anything about the
So in the terms of answering questions, whether they be of an epidemiologic study or health services, one difference that we may find is in health services may be using group data more often, claims-based data, administrative data,
hospital discharge data. These most often are national databases of hospital discharge, or they, could be state databases, and it is instrumental to always have a section in your report that describes how the data were collected, by whom, what was done after the data were collected. Are they raw? Are they crude? Were they somehow corrected? Was there analysis run on the data to impute missing data, for example? Because any of those items could affect the quality of the data, the use of the data, and how the data are important. So it's fine to use these databases as long as you know if there are limitations, and to take into consideration the limitations when you are making conclusions based on those data. Is there an example in the text that showed differences in magnitude of rates using two different data sources, National Hospital Discharge Survey and the National Health Interview Survey, with the outcome of short-stay hospital discharge rates. As you see, you kind of look at the dotted line and the full black line. They look similar, but as I was mentioning, if you then go over to the axis, you see that you have quite a difference in magnitude of what is being reported or what is contained in the database. And you start asking questions, well, why are we seeing these data? They're both coming from United States as a source. They are both national. One is discharge survey and one is from National Health Interview Survey. And so what were the procedures used for collecting the data? Hospital discharge survey, you're getting data directly from the hospitals in terms of their administrative databases. National Health Interview Survey is actually a series of interviews that are conducted on an annual basis. There's a core set of questions within the National Health Interview Survey, and then each year, every other year, they do different modules so that we can learn more from this vehicle of data collection. And so, once again, clearly understand where your data are coming from. Is there anything that occurred that could explain why you're getting a bump in your line, or why you are seeing it ascend or descend? Perhaps it was due to just switched over to electronic medical records. There's new things captured, things that we stopped capturing. So constantly question your database before making definitive conclusions. Outcomes research studies the end results of medical care, the effect of the healthcare process on the health and well-being of patients and populations. and a nice general definition of outcomes research, and the type of issues that would go under the rubric of outcomes research. Some examples: effectiveness goes into a specific type of outcomes research, comparative effectiveness, and then all the methodologies and analyses that are being developed around that new area of interest. Impact of insurance status or reimbursement policies on outcomes of care. What are we talking about now on a day-to-day basis of the effect of the Affordable Care Act on health outcomes, population health? We're all spending, just a lot of time reframing our questions. Okay, things have changed. What effect will that have on our national databases, on our vital statistics, on this, that, and another? What effect will that have on healthcare in general? So really a key significant issue, timely issue. Development and use of tools to measure health status. Even though it sounds like we should know what the health status of the Johnson City population is, we don't. Depends how we measure it. What are we measuring? What should we measure? What is health? How do you define health? Getting back to the question about standardization of measurement, the use of definitions, so important. Groups all define health differently. It just seems so simple, but it's just so hard. So that's important. And then ways to disseminate results of outcomes research to both the providers and the consumers. Important. Once again, a whole new science that we are trying to establish valid methods for. Implementation and dissemination science, okay? We keep churning out this research and using resources, and is it really making an impact on those that it should make an impact on? How do we get the information to the providers? In terms of, you know how it is as a student, there's just information coming at you at all times. What is the best way for the instructors to get information to you? We, most often don't do it in the best way. Similar questions: how do we get the information out to the busy healthcare providers who have to see, a patient every how many minutes? All these, the internet, the sites, what to monitor. How best to package information to send it out to the consumer so he or she doesn't have to sit there and say, okay, is this a reliable site? Should I believe what they're saying? Implementation and dissemination science has become a key hot topic. Places that need some innovation, creative ideas from hopefully some of you can guide us on what best to do. What makes outcomes research different? It asks different questions. The setting that it studies is primarily healthcare settings. Health status measures, it may include different types of measures, and then methods used. a lot of secondary data analysis, but a lot of epidemiologists also do a lot of secondary data analysis. Different for some, not for others. But it really has become a science in itself, a discipline in itself. We're not going to. In terms of items you should think about, that of characteristics of grouped data, and it doesn't matter what type of grouped data that it is often this data has been collected for purposes other than the research question, okay? So the research question is not driving the data to be collected. The data are there, and you have a research question, and you look for the most appropriate group data that could potentially answer the question that you have. The data may be incomplete. Once you get into large data sets, you begin to have the issue of missing data, or otherwise called messy data. There are methods to deal with that. You need a mathematician who understands your data set, statistician. They're very complex methods sometimes that need to be used. Once again, a science in itself in terms of the development of appropriate analyses for large data sets. Something else that has been sprung upon us is the generation of big data, whether it be because we are now in the era of electronic health records, or that we have genome-wide databases, or we now realize that the microbiome is so important for our health. We've entered into the era of big data and all the issues, complex issues that are brought before us. Limited information about confounders, which is true. You really need to think of confounders in a prospective fashion, and so it's a similar situation to missing data. You're probably not going to have the information about confounders. For that reason, and also because it's an administrative data set and they don't have the resources, they just can't collect everything. Often the data are collected for billing purposes. Remember, these are large businesses, and so they are trying to keep their business afloat. They're not necessarily there to create data sets for research. And then the investigators that use the secondary databases, they often are not the individuals that were involved in the developmental phase of the databases. You can think about these large secondary data analyses as ecological studies. A good place to start are the example that we had at the beginning of the semester was Ansel Key's data on countries and the pattern of what the populations were eating, and his hypotheses of, these countries are the high salt intake countries, and let's graph that in terms of amount of salt intake, and then let's graph the cardiovascular disease next to that line, and come up with an ecologic hypothesis that salt intake is potentially associated with incidence of cardiovascular disease. So those are the type of general broad statements that you can make with the large databases. Okay, artifactual relationships. Relationship of prenatal care to birth outcomes. Let's see. A woman who delivers prematurely will have fewer prenatal visits. The result would be an artifactual relationship between fewer prenatal visits and prematurity, only because the period of gestation was shorter. Okay, so that's one of those trick questions. She had the child, infant was born prematurely. What does prematurely mean? It was born before full gestation, and so if the child had not been born prematurely, the woman would have had an opportunity to potentially have more prenatal visits. And so just sort of the caveat of the data. You get what's there. And sometimes you may not have the appropriate linked data, and so you may have a database of prenatal visits, but you cannot control for the fact that some of those visits that are associated with a woman are also linked to a premature birth. But all these things you have to think about. Getting back to biases, our bias of self-selection. Let's talk through this example. Women who choose to begin prenatal care early in pregnancy, are often better educated and of higher SES. And that is a statement, a true statement. Thus, women who begin with, women who to begin with are at lower risk for an adverse birth outcome select themselves for earlier prenatal care. The result is a potential for an apparent association of early prenatal care with lower risk of adverse pregnancy outcome, even if the care itself is without any health benefits. I know. All right. Who would like to talk through that wordy paragraph? You've got a sort of take that first statement as a statement of fact. Women who choose to begin prenatal care early in pregnancy are often better educated and of higher SES. And so how are you going to use that information to discuss that paragraph? What's happening here is you're getting a washout of effect. Okay, you've got two different types of women. You've got those that are better educated and higher SES. They're going to they're going to get into prenatal care early. That's what they've been told, and that's what they've learned through their education. They're getting into care early, and so the even though there are women who even I can't find the right words. All right, women who begin. Women, I keep reading this incorrectly, that's my problem, and you're all saying, see what happens when you take these multiple choice exams? Women who, to begin with, are at lower risk for an adverse birth outcome select themselves for earlier prenatal care. and then that's from the information in the first sentence. Thus, women who, to begin with, are at lower risk for an adverse birth outcome select themselves for earlier prenatal care. They select themselves, okay, due to education. The result is a potential for an apparent association of early prenatal care with lower risk of adverse pregnancy outcome, even if the care itself is without any true health benefit. It's what they're getting at is the use of prenatal care as a piece of data and using that only. Remember, we're talking about group data, and so we're taking prenatal care, and we are not linking it to the outcome. Okay, we're saying prenatal care. And we're also not linking it to the type of health care received. All right, we're just taking two variables, and we're not thinking about those other variables that could have an effect, on those two variables.
That was my question, if SDS is a confounding variable. Okay,
Mm-hmm.
I thought they were.
Mm-hmm.
Okay.
Individual data, sometimes preferred over group data. We can sometimes overcome limitations of group data, okay? We can have collect information on both the exposure and the outcomes. We can observe how things are happening. We can collect information on confounding variables, and will provide us with a more robust data set, a valid data set, something in which we can actually make definitive conclusions with. You can use randomization in terms of type of health program services to that you would randomize your patients to. Certainly, as long as you are not doing something deleterious. This is often used for you have standard of care and you're questioning, what if we do this? Okay, you can randomize your subjects, your patients into standard of care versus some new type of care and ethical. Great design to use. We know that the randomized trial is up at the top of our pyramid in terms of robust data. In terms of some non-randomized designs, once again, just for you to be aware that there are non-randomized designs that are used, and brief descriptions, before-after design, one in which epidemiology would call the use of historical controls, compare one group who received care before a new program with another group who received care after the program. So we're going to be seeing a lot of comparisons of pre-post Affordable Care Act, okay? This is what we had. Now we have Affordable Care Act. Now this is how it has either had an effect or not an effect on population health. But, you know, there's a lot of things that could differ between pre-Affordable Care Act, post. Bring that up into your limitation section, but that's one way that you could study a new health insurance effect on health. Simultaneous, non-randomized design, program, no program, similar to community comparisons, one community gets the program, another community doesn't get the program. One population gets a health care service, another population doesn't get health care. Utilizers and non-utilizers, in terms of utilizers of health care, you're going to probably have a much better data set of utilizers only because they are utilizing and they are you are collecting data on them, and so you have a record to compare to, for example. Eligible, non-eligible individuals selected for eligibility, and then see what happens. And so in terms of eligibility, are they eligible for a certain service? Are they eligible for insurance? Are they eligible for health care? Case control studies. We'll know about case control studies. Using case control studies in terms of the design, the limitations, the strengths and the weakness, no matter if they're used for health services, epidemiology, healthcare, blood. A case control study is a case control study, and you retain the strengths, weaknesses, and their purpose. So many of the issues that arise in the evaluation of health services are similar to those we see in etiologic studies, okay? And remember, etiologic studies, we are trying to learn causes of disease, causes of health, causes of disability. The focus in evaluation research is often on different issues of measurement and assessment. So you're collecting different types of data, asking different questions, but you can use similar approaches. The randomized trial remains the optimal method for demonstrating the effectiveness of a health intervention, just as long as you are not creating risks for individuals that you're studying. You can use the randomized trial. And then for practical reasons or because it's not ethical, non-randomized observations are also necessary and must be capitalized on in the attempt to expand efforts at evaluation. Yes?
Just have a question, because something we talked about a few weeks ago was the ethics of offering treatment that you know will work, and the ethics around not offering that treatment to another group once it's been proven to work. I'm just curious on the population level, if you have an evidence-based program that you know has shown, in other places, for instance, to reduce, early onset diabetes or some intense health issue, what are the ethics around offering that to one group and not offering it to another if it's evidence-based and been proven to work?
Okay. And are you saying as an investigation or in practice?
In practice, how is it ethical to implement that if you're, I guess maybe in investigation, because that relates to.
Okay, I'm gonna, all right, let me start with this. Perhaps you don't have the resources. Perhaps it costs $50,000 a year to put someone on treatment, and you don't have that. So you cannot offer it. That's one example. It may take up resources other than dollars, so it all kind of goes back to dollars. You don't have those resources.
We've talked about this at the population level in our health policy class.
Here's, and I don't know why this is popping into mind, but it is. Okay. Think about school lunch program. We know that a diet rich in fruit, vegetables, low in fat, low in sodium is better for growing children school age. all school districts don't adopt those criteria. Even those that are providing a lot of, what do they call that? Lunch-free, school-free.
Free-and-reduced lunch.
Yes, thank you. You know, we know we should be providing it to everyone's population, school-age population. For some reason, we can't. We don't have the proper, quote, kitchens to prepare mass quantities. We don't have the budget. You know, that's one of the unfortunate things. We know that, quote, healthy food costs a lot more than the 2-liter jugs of soda and potato chips and everything else. And so I'm not sure that's getting to your question. But, yeah, there are a lot of things that we know and we should be applying, but we don't know how to apply. Okay, we don't know how best it works, whether or not it will be accepted. There you go, those school lunches. I'm not eating that. I want the pizza. Is it acceptable to the population? So yeah, those are some of the things. You know, are folks satisfied? We know that secondhand smoke is not good. So now what are we looking at in terms of subsidized housing? We now want to say, no smoking in subsidized housing. How is that, how is that going over? Not going over very well, is it? So yes, good question. There are so many things that we could do, but we don't know how, or it's not accepted by the population.
Or how do you pick which group?
How do you pick?
That was kind of where I was getting at.
How do you pick that is a good question, and that's why we often begin with qualitative information when we start. And you know this, talking to folks. If you start talking and you get resistance, okay, not the time to implement, but let's see how we can slowly implement. And does it get to the point where it becomes policy or it becomes law? It's hard to change behavior. Did anyone have the opportunity to go to Dr. Tom Farley's Leading Voices, where he years ago was, well, not years ago, a few years ago, was Commissioner of Health, New York City, where he was the one that was actually, he had followed the current CDC director who had started that whole thing of working with Mayor Bloomberg, who is the #1 public health advocate. And, and it's great, he's got money too. The whole thing of getting calories on fast food menus, not restricting consumption of high sugar beverage, but restricting the size of the containers. Hey, fine, if you want to go and buy 3 small containers, that's okay. But you cannot buy 1 large container. So now it becomes an economic issue. Putting taxes on cigarettes, I mean, I don't know how much a package of cigarettes cost, but if you went to New York City, it'd be like 4 times, 5 times, probably 10 times the amount that you would pay in Tennessee. And those are the type of things that they needed to institute in New York in order to see changes. And they have seen changes. Their obesity rates are going down. Amazing. But it was through policy, law, things that were hitting people in different ways. As I say, hitting their wallets, having to make those type of choices rather than, today I'm going to start a diet, I'm going to go run 6 miles, and I'm going to do this, and I'm going to, Like I was saying, right. You may have seen me at the wellness center, but you probably not seen me there for, unfortunately, a while. But you know, at least she saw me once. But anyway, hard questions, right? Don't they seem sort of like, gosh, we should be able to do this, but they're just such hard questions. Okay, thank you. That's good. Okay, let's reconvene at 3 o'clock, and we'll go to chapter 18.
Looking at the status.
We will be a lot more relaxed. You're like happy, it's gonna be like
It was.
Good, how are you?
And it well, my okay, yeah. So I found the data for nationally, how many females I feel like it's there, but it's not I'm really close, and then there's a female. Yeah, females means data, and then I have like state data, more
Sorry, can you know what talking every day. Oh my God, I have so many. I literally go like checking for it. I'm not like cut it. Just yeah, that's fine. How did you get over it? You don't get over it. Sometimes
there's
Yeah. But that's sticker.
I'm just wearing a clean clothes every day. Because we don't have like bigger size. We don't buy that right? There's like a big size.
I was the only one of that. That and my going through
I have the yeah, a couple of one back here. During pregnancy, that 10 days you don't gain, you are like dead. You start eating protein to feed the baby, right? So you have to eat all that meat and all and when you're not feeling you know it's like I can't imagine yeah, I cannot.
Okay, chapter 18, evaluating screening programs, and we're using once again what we already have learned about types of study designs, when to use them, appropriate uses of study designs, discuss bias, and we discuss screening. And so, what is secondary prevention? Screening. And so you know about primary prevention, secondary prevention, tertiary prevention. And so reiterating that a major aim of epidemiologic studies is to identify modifiable risk factors so that the disease can be totally prevented. Primary prevention is where we spend much of our efforts. Not smoking prevents lung cancer from happening in some. And so throughout this chapter, you were learning more about how epidemiology is used to evaluate the effectiveness of screening programs for the early detection of disease, meaning that not all screening programs are equal. Some are better than others, and what can we do to make sure that we are using the most appropriate screening programs for the population of interest. Secondary prevention remains an important activity for both clinical practice and public health. We're still concerned with the validity and reliability of screening tests. We need to think about the concepts and principles that we've learned in terms about sensitivity and specificity, positive predictive value, negative predictive value, and how they are, knowing what they are can help us to evaluate our screening program. And so what are the benefits of screening?
Early detection.
And in the long term, early detection can lead to what? Better health outcomes, and also in terms of cost of care, can reduce cost of care, can reduce necessary resources, allow those resources to be placed somewhere else. Really very key. We want to make sure that we are effectively using our resources. And so it's your job to set up a screening program, and you need to place these questions in front of you and determine how they affect your draft proposal. Can the disease be detected early? In the case of hypertension, it can. It's such a cost-effective thing to do. I mean, you know, they even set up little blood pressure stands in the grocery stores. An example of how a disease can be detected early, meaning that there are something that can be measured and interpreted. What's the sensitivity and specificity of the test? You want something that's both highly sensitive, highly specific. We know we usually can't have that, so depending on what we're looking for, the characteristics of the disease, at what point we are in our program, whether we want a higher sensitivity or a higher specificity. Predictive value of the test. We don't want a lot of false positives. Because, you know, how serious are the false positives? What's the effect on long-term patient satisfaction of being told that you have a condition, a disease, a disability, when in fact you don't? What's the cost of early detection? Gosh, if we find something early, do we have the resources to provide you care or treatment? Or there may be nothing that can be done. Are the subjects harmed by the screening test? And remember, harm doesn't necessarily mean, we usually think of physical harm. It doesn't, could be mental harm, could be social harm. And we spoke earlier about social stigma. A real significant issue that we dealt with in the early 80s with the diagnosis and screening for HIV. Finally, you know, gotten over that, to the point of it's a chronic disease that can be treated. Individuals will probably die of something else. Do individuals in whom the disease is detected early benefit from the early detection, and is there an overall benefit to those who are screened? And so important questions to think about, particularly these last questions, something that the investigator, the researcher really isn't the proper person to, appropriate individual to answer some of these questions. We need to get feedback from our populations, from our clients, from our participants, and learn from them. Is it acceptable? You know, we think we may know what's best for you. How can we begin to go towards a common ground? So some benefits is that an appropriate intervention is available, an assumption, and that the intervention can be more effectively applied if the disease is detected at an earlier stage. Perhaps less invasive, less costly, more acceptable by the individual. Although it may seem obvious that people will benefit from early detection of disease, that may not always be the case. Is it an emotional burden for the individual? And many of these questions now come up with the genetic screening tests that are available, really just about to anyone, where you may send in a swab to a company, and they will come back and give you some information that may be useful, may not be useful, or some information that you can discuss with your healthcare provider. May come back and with information that you're at risk of every disease conceivable on the face of the earth. I don't know. And so it should not be assumed that all screening will benefit. Another interesting to think about are these screening companies that are popping up. They're businesses. What do businesses need to do to stay afloat? They have to make money, sure. And so are they making money off their clients? Are they providing reliable, valid information? I don't know. Perhaps they haven't asked themselves the appropriate questions regarding the benefits of screening and how those data are used once they are disseminated. And so, key, what is the benefit that is gained? And it doesn't help if those screenings derive no benefit. Just as we had some operational measures of health services in terms of programs that were that are conducted, places of locations of healthcare, in terms of effectiveness, you might be interested in the number of people screened, proportion of the target population screened, number of times, proportion, prevalence, cost, cost per case, interesting, cost per previously unknown case found, another interesting scenario that you can then begin to multiply out. If we are able to identify 10 new cases that we did not know of prior to the screening, what's the long-term effect? How much money could we save? So you can put together some nice case scenarios as to why your screening program should be adopted. predictive value of positive test and population screen, because remember, the characteristics of your test can differ depending on what population you're using it in, depending upon the prevalence of the disease that you're interested in, your test characteristics will differ. What do you want to see if your screening program has been effective? You want to be able to reduce mortality, morbidity, reduction of case fatality, increase in percent of cases detected at earlier stages if you can in fact deal with those earlier stages, reduction in complications related to both the person and cost, measures of cost, prevention of reduction in recurrences, and improvement of quality of life, something that we're finally bringing into the whole circle of evaluation, is that, you know, you're dealing with people. It's their life, their quality of life, and understanding how that fits into their environment. So as we mentioned, how do we identify persons with disease who are asymptomatic? Sometimes it just cannot be done. We have, let me get to many of these diagrams in this chapter in terms of sort of all starting with the same thing, from no disease to clinical outcomes, and the different phases that we can term the natural history of disease, and starting, as I was saying, with no disease in A to advancing to preclinical, advancing to clinical phase, and at what point things outside influences can take place on trying to slow the process, stop the process, or prevent the final outcome from occurring. Let's see, one of the new terms in this chapter is lead time. We had not discussed that previously, and that is the time that the outcome is detected prior to the usual time of diagnosis. So there is perhaps a new screening program or methodology that allows you to detect the outcome sooner than what is usual, and that is called lead time. And that may have a different effect on the course of events depending on what you are measuring, what you are looking at, what you are following. Another term that was introduced in this chapter is the concept of critical point in the natural history of disease, being defined as a point in the natural history before which treatment is more effective and or less difficult to administer. If a disease is potentially curable, cure may be possible before this point, but not after. And once again, it's going to depend on disease, disability, whatever you are looking at. But the crux of it is if a disease is curable, cure is possible before this critical point, but not afterwards. Why might that why might it be important to know what the critical point is for a disease or outcome?
When you're using like screening methods, you want to try to catch them before the critical point to get a better outcome.
Certainly. So it will really help you guide the processes you put in place in terms of your health services and help you to make other decisions. Two important conditions for screening to be of benefit. All or most clinical cases of a disease first go through a detectable preclinical phase, okay? You want to make sure that your screening allows you to detect something sooner than usual. In the absence of intervention, all or most cases in the preclinical phase progress to a clinical phase. That's in terms of benefits, taking into consideration disease progression and screening. With examples, if none of the preclinical cases progress to clinical cases, there is no reason to perform screening testing. Okay? You're preclinical, and you just sort of stay preclinical, and there's no chance of you to progress to clinical. No reason to perform a screening test. You're not detecting anything that will allow you to then intervene. Or, on the other hand, if none of the clinical cases passes through a preclinical phase, there is no reason to perform screening tests. You're not picking them up earlier than you will by following standard practice, standard of care. And so, you know, think of both cases always, the alternative, with the caveat of both assumptions are open to question. Because of new knowledge, new technology for a disease or outcome in which the clinical case, you may learn that the clinical case actually does have a preclinical phase. Now you have a different test available to you that is able to detect a preclinical phase. Then you have to change your thinking. You have to change your service process. In Chapter 18, you were given the example of the natural history of normal cervix to invasive cervical cancer, and the fact that it is not as simple as a straight line natural history, but the fact that you your test can revert back to normal, but the importance of continual screening. Methodological issues in terms of designing robust screening programs. Most of the screening programs that are used, many medical procedures, tests, have not been subjected to randomized trials, and that is okay, even though we do use that as our pinnacle test. But there are, once again, those cases in which we cannot subject human subjects to the experimental design. This chapter, as you, when you want to review this chapter, go back to the conclusion section at the end of the chapter, and it reviews what the chapter is trying to emphasize. And one of the emphasis in this chapter is discussing bias in the context of screening programs. And so, once again, how does one apply the concept of bias in the real world? How does bias potentially influence a screening program, meaning that the screening program may not be successful if these biases enter into the program. Selection bias, type of volunteer bias. People who volunteer to participate in a study, once again, are often different than non-volunteers. Whatever that study be, whether it's a screening study or an etiologic study, volunteers are often different due to past experiences with healthcare, past experience with disease, and so we try to conduct randomized experimental studies. If we can, we know that we often cannot. The length-based sampling comes into play here. This type of bias for screening. At what point of the disease is this individual entering this study? Because as you think about the timelines that were presented to you in Chapter 18, it depends where you enter the screening program on the continuum of the natural history of disease from no disease to either disease or death, could have an effect on the results that you get. If the outcome of those in whom disease is detected by screening is found to be better than the outcome of those who were not screened, could the better outcome among those who are screened result from selective identification by screening of persons with a better prognosis? We don't know, but those are the questions that need to be asked and evaluated if possible. Selection bias, link bias sampling continues. Once again, this is all in Chapter 18. Lead time bias, examining survival in people who are screened and then comparing it with survival in those who are not screened. How much earlier can a diagnosis be made if the disease is detected by screening compared with the usual timing of diagnosis if screening were not carried out? Early detection and diagnosis leads to what looks like longer survival, only because disease is detected potentially earlier because someone has been screened. It doesn't necessarily mean that there is a longer survival for those that are screened versus not screened. And all of that needs to be mapped out and questioned. Overdiagnosis bias, another type of bias that could enter into the evaluation or investigation of a screening program. So once again, you can take these concepts and go from setting to setting and still think about them. How can this non-random error enter into what I am doing? You all know that there are the non-randomized studies that are available to us. We don't randomize with a cohort design. We don't randomize with a case control design, but they are available to us if the randomization study design is not appropriate, not ethical for what we are looking at. How should we address results that show no benefits of screening? The apparent lack of benefit may be inherent in the natural history of the disease. Once again, as we mentioned, it just doesn't have a preclinical phase. There's no phase that is appropriate for screening, and so there's just no benefit to do a screening for that disease. All screening should not be conducted for all diseases. The therapeutic intervention currently available may not be more effective when it's provided earlier than when it's provided at the usual time of diagnosis. So then again, you're throwing out money. You're not effectively using your resources. And so you should just wait for usual diagnosis. And then another example of showing no benefit of screening, the natural history and available therapies may have the potential for enhanced benefit, but inadequacies of the care provided to those who screen positive may account for the observed lack of benefit, meaning that it's now on the other side. Everything is available to help the screened individual, but the care that they are being provided is not up to stuff. It's not adequate. And that's where you probably need to get into some of that health services evaluation and investigation to determine why is the health care not as good here as it is over here. We know the screening has been adequate, effective, but once we now place them into the healthcare arena, it's the outcomes that we're expecting we're not seeing. Once again, a lot of cost-benefit issues surrounding screening. We've discussed several of those. Don't need to reiterate there, but I think that criteria that are established by accepted, well-respected groups are a good place to start. Here, examples of what was used for the American Cancer Society, a little old, 1980, but there must be good evidence that each test or procedure recommended is medically effective in reducing morbidity or mortality. That's what we want to do. We want to go towards our long-term outcome of reducing morbidity or mortality. Medical benefits must outweigh the risks. The cost of each test or procedure must be reasonable compared with its expected benefits, and whenever we get into using terminology such as reasonable, that is just something that is accepted based on expert opinion. What is reasonable to one may not be reasonable to another, and so it must be backed up with justification data. And then the recommended actions must be practical and feasible. Practical for the individual, feasible, and also I would add acceptable, which is often related to feasible. an example of a pap smear test that is used, accepted, feasible, but will never a randomized controlled trial of cervical cancer screening. Has not and will never be done. And basically, the practice is widely accepted and by health authorities, the general public. We've seen the benefit. We've got data supporting the screening procedure, and so the randomized trial, even though it was not, the practice was not established with a randomized or experimental trial, it just, there's no need to do such. The what one might do is there over time would be potentially randomized trials that would compare new screening tests or devices to standard of care. And so that's how pap smear might be included in a randomized trial, but it would never be included in a randomized trial. That would be pap smear to placebo, for example. This slide just getting back to the point of we've never found it necessary that we sort of go backwards and say, oh, wait a minute, we stopped, we cannot do the screening anymore because it's not based on randomized trial. We've looked at that issue using different types of study designs, in this example, case control studies, and have realized that we would not need to do that. So, getting to conclusion, few of the methods that are currently used to screen for early disease have been evaluated by randomized controlled trials, and most will not be studied this way. A lot of just the horse came before the cart in many ways in terms of the practice of medicine as an art versus a science that has changed with our introduction of evidence-based medicine. But what we have learned, what we practice, is still providing us with good health care and good population health. This is a result of the difficulty and expense of such studies and the ethical issues inherent in randomizing a population to receive or not to receive care. We have had some opportunity to test some of our medical technology in lower resource countries that are trying to build their resources and decide what direction is best for them as a population, for them as a nation, and the randomized trials may be appropriate in those cases, where we would all learn a little bit more. And then evidence from non-randomized approaches must be used, but we need to consider the biases that are associated with a cross-sectional study, the biases that are associated with cohort studies, the biases that are associated with the case control study. Those biases will always be linked, potentially be linked to those designs. That's just how it happens. Let's see. In approaching programs for early disease detection, we need to be able to identify groups who are at high risk, not only for developing the disease in question, but also those who are at risk for benefiting from the intervention. Once again, giving you the appropriate approach for screening programs. And then the final decision in carrying out a screening program should take into account the incidence and severity of disease. Once again, very important because your diagnostic tests are going to perform differently depending on this. The feasibility of detecting the disease early if you can't detect it early. Once again, don't waste resources. Feasibility of intervening effectively in those with positive screening results. Don't hand out a positive screening result if there is no follow-up. And then the overall cost-benefit calculation for early detection. So a lot of things to think about, interesting things. Very interesting, as you all mentioned earlier today, implications of policy, effect on the population, on the public's health. So I'm stopping there. Questions from anyone? Okay, thanks for coming. No class next Wednesday, okay? Even though it's a real day, we don't have class next Wednesday. Have a wonderful Thanksgiving, and we'll see you in 2 weeks. You too.
All right. Wow.
That was one website, and then this is from family. That's kind of like 6 days. past.